Good morning, everyone. As we move into session 2 of the workshop, we're going to be transitioning into a discussion of measurement and analysis. The nexus of agriculture, food systems, and health requires multiple data inputs and novel methods of big data analysis and systems modeling. Simply put, policies aimed at assuring the future of food require the best data and latest methodologies, and it is the goal of this session to explore these methodologies and policies. Our first speaker, Ashkan Afshin, is Assistant Professor of Health Metrics Sciences at the Institute for Health Metrics and Evaluation at the University of Washington. He will kick off our session of measuring and quantifying the burden of disease from dietary factors, drawing on his work with the Global Burden of Disease Project, as well as his training as a physician and epidemiologist. Ashkan?
Good morning, everyone. It's a great pleasure to be here. The focus of my today's presentation will be on data landscape for diet, and I will start with providing an overview of the common challenges that we have and the solutions that, as a part of global burden of disease, we have developed, and also briefly discuss what we know and what we don't know in this area. Any individual who has worked on dietary data at the population level most probably has experienced some of these limitations. In terms of availability, dietary data are limited and scattered. Not all data are in public domain, and dietary data are inconsistent across countries and also within country across different sources. And there is no food system approach in data collection for dietary data. These challenges are very similar to the challenges that we face in health system. Over the last 2 decades, the global burden of disease has developed different methods to address these challenges. And over the last decade, we have tried to basically apply the lesson that we learned in the health system to the food system and try to address these challenges by using these common solutions. Basically, we have tried to systematically identify all relevant data sources related to diet and food system, standardize the data across various sources, and correcting for known biases in data, estimate all quantities of interest and the uncertainty associated with them, and communicate them with the public and policymaker, ensure internal consistency in data, and harness new data sources and new data processing methods as they become available. This slide shows, this is a simplified version of our estimation process for dietary data. and as you can see, we use different data sources. We have, on the left-hand side, you can see we use data availability from UN FAO. We also use data on sales and purchases from different companies and different, basically, associations. For example, Euromonitor is one of the examples of those. We also use data on expenditure on different food products, household expenditures, and also data on dietary consumptions, whether they come from 24-hour dietary recall, food frequency questionnaire, and for some specific dietary risk factors where available, we use biomarker. For example, for sodium, we use biomarker to assess the daily intake of sodium. And then each of these data have their own limitations and strength. The lesson that we have learned over the last few years are that basically no single data source is perfect, and each of these has their own challenge, their own strength and limitation. For example, food availability data, they have a great coverage both in terms of the time and geography, but they don't inform. They do not basically provide data on consumption. They include data on waste, and also they do not provide data on age and sex pattern of the consumption. Sales data are great, but for low and middle income countries, they are not of good quality, and also they only helpful in informing recent trends in consumption. Also, they don't provide, many of the sales data, they don't provide information on age and sex pattern of consumption. On the other hand, dietary consumption data, for example, food frequency questionnaire and 24-hour dietary recall, they are good in terms of providing data on age and sex pattern of consumption, but we don't have a good geographical representation of those. And also, over time, there are very limited data sources that basically can show the trends in consumption. And biomarker, they are not available for all nutrients and also for all foods. So there are very limited data available. So what we have done in the global burden of disease, we have tried to combine all of these data and also adjust for known biases and make them comparable as much as possible. Here you can see the map of data that we are using in the global burden of disease study. On the left-hand side, you can see total sources of that are available for each country. On the right bottom, you can see the time trend of these data. For example, before 1980, almost all the data that we have are food availability. And then in recent years, we have more data on sales. We also have some data on household budget surveys and very limited data on dietary consumptions. And on the top right, you can see the number of data sources by different regions. In global burden of disease, we divide countries based on their geographical location in 7 different super regions, and you can see how much data we have for each super region. As I mentioned before, as we collect these data are not comparable, so the first step is to make these data comparable. Previously, we were used a conventional statistical model to basically make these data comparable. We match data from the same countries, basically by wherever the data available by age and sex, and if not all age group, we match them by age, country, sex, and year, and see what is the relationship, and we try to basically estimate those relationships and apply those relationships to the countries that we have only one type of this measurement, and correct for known biases. In recent years, specifically in the last round of GBD, we tried to use more advanced techniques such as machine learning and artificial intelligence to characterize this relationship that basically we realized that using this novel method significantly improve our estimation process. Here you can see the basically different models. I don't go into the details of them. I just show you the comparative performance of the model. The first model is basically we try to estimate the intake based on availability data by age, sex, and GBD super region. Then we use the same data to train two different machine learning methods. And here you can see, and we've tried to compare the performance of these models based on how they predict the data that they have not seen. Basically, we try to assess the out-of-sample predictive validity of each of these three models. And on the right, you can see the out-of-sample correlation for the conventional statistical data. This is what statistical method. This is what we had used in previous rounds of GBD, with the out-of-sample correlation of 0.45, which is still in the diet area. It's a good correlation. It's the correlation between dietary recall and multiple dietary recall for many food groups. But using machine learning method, both random forest and XGBoost basically significantly improve our out-of-sample performance, and we got the basically correlation coefficient of 0.95 and 0.92. After making and these data are related to vegetable, we did this for all the different food groups that are included in the GBD and also for nutrients. And for many of them, the out-of-sample correlation was above 0.8. After making these data comparable, then we try to combine all of these data and generate one single estimate of dietary consumption by age, sex, country, and year, and we annually update this process. To do that, we are using a statistical method which is called a spatiotemporal Gaussian regression, Gaussian process regression, which borrows information across different age group for the same countries, neighboring countries, and also borrows information across time. Here you can see the estimates that, for example, we have generated for the meat intake in the US, and each box shows one age group. They are divided in 5-year age group. The x-axis shows the time trend, and the y-axis shows the basically gram of intake of meat. The circle shows the mean estimate, and then the vertical line shows the uncertainty estimate. As you can see, basically the data that goes back in to 1980 to present, most of them are FAO data. In recent year, we have data for sales data in the US, and also we have some scattered data which are related to NHANES, which is basically nutrition surveys that we have in the US. And then these are the data post-adjustment, and the line that you can see and the shade shows our estimate that we have generated for the meat intake in the US after taking into account all of the data that we have available. And we replicate this process on an annual basis, include new data, include new model, and we do that for all dietary factors that we include in the global burden of disease study. Then the next step, through this way, we generate the mean intake, but not all the people are consuming dietary factors at the mean level. We have a distribution. So the next step, previously we were using, again, known statistical distributions, such as log normal distribution. As of 2 years ago, we developed new method, and we combine, based on a micro data that we have individual level data, we combine 12 different families of the statistical distribution to better characterize the intake of different dietary factors. Here you can see the shape of a distribution that we have, for example, for legumes and vegetables. And to estimate this, we need to know the shape of a distribution, we need to do the mean intake, and also we need to do to know the we need to have another piece of information, which is basically a standard deviation of intake. We estimate the standard deviation of intake based on the relationship of mean and standard deviation that we have observed in different populations. We also need to account for within percent variation over time. If we just rely on dietary intake on one date, we are overestimating basically the standard deviation. But we need to correct that by take out the daily within percent variation to go from a one-day intake to usual intake, and this is also helpful in terms of when we are estimating the high intake or low intake of specific foods or nutrients. So here you can see, for example, after going through this process, here you can see the intake of, for example, fruit in 2017 in all countries around the world, and the legend shows the daily intake of fruit in different countries, and you can see the recommended level of intake based to see the optimal health effect is generally between 200 to 300 grams per day, and many countries are below the recommended level. On the other hand, we can see the basically same age group, male red meat intake around the world, and you can see for for many countries, the intake is basically above the recommended level. We also, if you are interested to see what is this relationship for other dietary factors, this figure shows the ratio of the current intake to the optimal intake, recommended level of intake, to see the optimal health effect at the global level and across different regions for fruits, vegetables, legumes, whole grains, nuts, and seeds. For example, for nuts and seeds, you can see we have a huge gap in the recommended level of intake and the current consumption at the global level, and also specific nutrients, for example, polyunsaturated fat, omega-3 fatty acid. Japan and countries in that area are outlier, but in many other countries, they are below the recommended level of intake. Using GBD data also allows us to evaluate, to answer other questions. One of the interesting questions that people ask is how people replace different food items. When people increase the consumption of a specific food item, specifically macronutrients, they should decrease the consumption of other things. For this scatter plot shows, for example, what is the pattern of replacement that we see across nation. One of the most recommended replacement for fatty acid intake is replacing saturated fat with polyunsaturated fat. On the left-hand side, you can see that what we see in real world, people do not basically make that replacement. In reality, when people basically decrease the intake of saturated fat, they increase the carbohydrate and vice versa, and which basically, and evidence from epidemiological studies shows that both of them are equally harmful. And this figure shows that each color represents the level of socio-economic status of the countries. Blue countries are the countries at the higher level of development. As you can see, as the countries develop, the level of carbohydrate consumption decreases and the level of saturated fat intake generally increases. So these are the challenges in the data in terms of incomparability of the data and how we make them comparable. But there are many other challenges in this area that I'm going to, over the next 5 minutes, I'm going to briefly mention some of the challenges that we have here. The first challenge that was mentioned, I think Adam mentioned in the beginning, is that how we should define diet. Should we define diet in terms of the foods, nutrients, or dietary pattern? Both of them have advantage and disadvantages that has important implications for how we measure them, data that needs to be collected. Should we care about the absolute level of intake or diet composition and the patterns of replacement? And they have different implications for estimating the health effect, also estimating the potential environmental impact of diet. The way that we handle this, at least at this point, the global burden of disease, we go back to, because traditionally our focus has been on health effect, we have gone back to the epidemiological studies that assess the relationship between different dietary risk factors and different outcome, and summarize the evidence, and we try to match our definition with the definition that has been used in epidemiological studies. But here we have a small challenge, and the challenge is that the definition of dietary factors are not the same across the studies. Here you can see the definition of, for example, whole grain across different studies. At the top shows, there basically each column shows the one study, the name represents the first author of the study, and the row shows the food items that are included or have been considered as a whole grain. And as you can see, the definition of the whole grain widely varies across the study. And one of our challenges is that how should we define whole grain in a study? Whole grain is perhaps one of the most challenging food groups. We have fruit seems to be a very easy, perhaps straightforward. But the challenge is that fruit itself is a very heterogeneous group. Both have there is no reason that we should believe that basically they have a same nutrient profile, and if they have a different nutrient profile, we expect they have a different environmental impact and also different health impact. And also there are some people have a strong opinions about what should be considered food and what are the basis for that. For example, cucumber, tomato, and eggplant. It's not clear. People have different, some people say that they should be fruit, some other opinion, and these are the areas that basically fundamental questions that there is no clear, straightforward answer. Again, for example, some people argue that we should focus on botanical definition. Then here, for example, we have a great example of nuts versus peanut. They have one belongs to the tree nuts group, the other is a legume, but they have an identical nutritional profile, and how we define that basically is another challenge. In GBD, the way that we are handling this, we are basically doing a data extraction at the food item level, at wherever we have data, and then we just use coding to regroup the food item as needed and based on different purposes. Serving size, it's a basically challenge that we have for food frequency questionnaires. One of the common data collection methods is food frequency question. It asks about average serving size, but estimating the serving size is very challenging. For apple, it might be straightforward. to estimate, to convert serving from grams, we generally go to the USDA database and estimate the apple. It's relatively easy, but it's not always that easy. For example, when it comes to broccoli, it depends on whether it's cooked, uncooked, and how people consume that. We are making a lot of assumptions here, and sometimes we have basically very arbitrary serving sizes. It's hard to quantify, and these are the assumptions that we make. And also, one of the challenges that we found in this area, the serving size varies across different studies, even in the same country. Here you can see the serving size of the salmon across 3 different sources, that the food frequency questionnaire that have been used in the US. And basically, if we go to other countries, we have different definitions, and we try to systematically collect them, but which of them is the correct serving size, people have different opinions. These are the areas that it's not very clear. We don't have a clear answer for that. In summary, if I want to summarize basically the lessons that we have learned, dietary data are far from being optimal, but we know that multiple lines of evidence show that diet is an important risk factor for the health of people and planet. And I would like to echo Jess' point that we cannot wait for perfect data in order to make decisions. Decisions have to be made now. And as a part of the global burden of disease, we have tried to develop methods to make the best use of current dietary data and characterize the human diet and also inform decision making. And we have tried to basically annually update data as basically new data and new methods become available and update our estimates. Thank you.